Richard is the Director of Respiratory and Neurology Services, as well as the Director of Radiology at Hurley Medical Center. And he is going to be presenting on Hurley Medical Center's efforts to reduce their length of stay and readmission rates for COPD patients today. Before I turn it over to Rick, though, just a couple of housekeeping notes. First, this work group session is being recorded. You might have heard that or saw the little pop-up, but that's good news for you because that means the slides as well as a recording of this presentation will be made available to you following the conclusion of the work group. Next, we will be holding questions until the conclusion of the presentation, but please feel free to add any questions as they arise to the chat throughout the presentation. We'll collect those and then offer those up to Rick at the end of his presentation. Lastly, your feedback is very important to us. If you've been to one or more of these work groups in the past, you'll know that at the conclusion of this presentation, we will provide you with a link to our post-work group survey, and we would greatly appreciate you complete that. As a reminder, for those of you that are here for participation in P4P credit, completion of that survey is mandatory to receive credit for your participation for your site. And with that, I will pass the torch over to Richard to start his presentation. I will stop sharing my slides, Richard, so you can.
All right. Hi, everybody. Can everybody hear me okay? Can you hear me okay?
I can, Rick.
Okay.
So I'm hoping everybody else can.
Yep.
No,
we can hear you.
Just wanted some verification. Hi, everybody. Thanks for having me. My name is Rick Barker. As Emily said, I'm the Director of Respiratory Therapy. That's kind of my wheelhouse for this presentation, but I'm also the Director of Neurology Services as well as Radiology at Hurley Medical Center. I've been with Hurley since 1998. I've been director since 2017 of the respiratory department. So I've been part of Hurley a long time. Started out as a respiratory therapist and just kind of find my way up the ladder in the ranks. So here I am presenting to you guys. I have no financial disclosures to report at this time.
Hey, Rick, we can't see your slides. Did you share them?
Oh.
That's okay.
Sorry about that. Can you see them now?
We can see them now. Thank you.
Okay, perfect. Okay. As I said, I have no financial disclosures to report to the group. Just a little overview of Hurley. We were founded in 1908. We're a 432 bed public teaching hospital. We are a standalone hospital, which obviously comes with some challenges, but they're challenges that we've always embraced here at Hurley. We see over 20,000 inpatients annually, along with 80,000 emergency cases. We are a level 1 trauma center along with a burn. We have an extensive burn unit, a level 2 NICU, along with PEDS ICU and PEDS emergency are our specialties. We are a children's hospital as well. This map just kind of shows where we land. We're in Region 3. Just a quick overview of the hospitals and organizations that are within our region. So we're located in Genesee County. As you can see, we face some challenges as far as income and poverty and education. As far as our population goes, Flint is kind of the center of our county, and we've seen a pretty drastic decrease in population over the last decade or so. Obviously, with the GM kind of pulling out some of their services and really affect our employment rate, our income and poverty rates, which leads obviously to increased health issues within the community, as well as access to services and things like that. We have a pretty high disability rate here in Genesee County relative to the rest of the state. Pretty high cognitive and ambulatory challenges that a lot of our patients face, which obviously creates issues and challenges to decreasing readmission rates. This is kind of where we fall as far as our patients that live in an at-risk or distressed zip code. You can see we have pretty high numbers. Most of the patients that we deal with are within distressed zip codes, again, creating more and more challenges. Overall, we do pretty well with our patients that are living in high risk areas compared to the rest of the nation. I think we do have a pretty large sample size when it comes to seeing these patients that live in these areas, but our readmission rates for those areas, we do a pretty good job of engaging in with those patients despite the challenges that we face with them. So this graph kind of shows where we're at. We're the black line here. We were rolling along pretty good in 2020. Our staffing was good. We had, our COPD navigator was fully functional. And then obviously, as everybody hears all the time, and COVID hit in 2020, which presented a lot of challenges as far as staffing our navigator. And with that, unfortunately, we've also seen a bit of a rise in our COPD readmission rates. We've gotten a little bit back on track, so we're hoping that starts to trend back down as it has a little bit, but we're still nowhere near where we would like to be. So our program goals. So we have a COPD navigator. We've had a navigator in place since I believe 2007. We were right there. We tried to stay with everybody and get on board with the navigator. We understood how important it was to keep these patients out of the hospital. So what the navigator does, pretty classic of most COPD navigators, our first goal is to educate patients to improve their self-management of COPD and the symptoms, to recognize their symptoms when they're running into trouble. We try to eliminate or reduce any triggers that, whether it's physical activity, whether it's in their environment. We try to help them reduce any triggers that may cause an exacerbation. We also try to identify and assist with any barriers that they may have. And obviously, our main goal is to reduce readmissions into the hospital. So what we do, how we kind of work our COPD navigator is our navigator has a work queue. We work with the Epic system, so we're able to work with them and develop a work queue and a work list for our COPD navigator. It identifies any inpatients that have a COPD diagnosis. He also kind of tracks patients to where if COPD is kind of their secondary, what they're in for, he'll still make some contact with those patients. Very important every time they come into the hospital for somebody to kind of talk with them, see how they're doing, and just keep that communication going, because communication is one of the barriers we struggle with our patients. So we try to be as proactive as possible in reaching out to them and making sure we're making some contact with them. Some of the navigator functions is smoking cessation education. We try to work with them, getting them into pulmonary rehabilitation. So we do an eligibility assessment for them. We do a lot of medication reconciliation and education, which obviously one of the biggest challenges is making sure that they know what their medications are, know what they're for, and that they're using proper technique. Make sure they have a spacer. Make sure that they're not getting their steroids mixed up with their rescue meds, a lot of things like that. We also try to help them with any financial issues that they're having, that we can possibly help them out with getting some medications. We also provide information on community resources for exercise, smoking cessation, and again, any financial information that we can give them for medical assistance. So some common barriers that we face, patient engagement is a huge one. Patient engagement post-discharge. A lot of our patients, unfortunately, there is only so much you can do. We try to do as many things as we can to keep the engagement going. But we do find a lot of patients, just whether they're not interested or they don't have the time or even the resources to engage post-discharge. Transportation is a big barrier for a lot of our patients, making it difficult for them to make it to follow-up appointments and pulmonary rehab. And then obviously the learning barriers for medication use and management, and patient access to care for a lot of our patients is a big barrier. So how do we address these identified barriers? So when it comes to engagement, our COPD navigator, he makes sure he consults the patient during the inpatient visit. We find that's the most important thing. And during this visit, he'll let them know what to expect. He'll discuss the best times to be contacted. He'll give them his number so he can be reached. He's usually available as soon as they call, but he always promises that he will get back to them. Realistically, he says within the next 8 hours he'll get back with them, but usually he's very available. But obviously for personal reasons, he has a life outside of Hurley as well. So he can't answer all calls at all times, but he's very available. And then we make sure he does a follow-up visit 24 hours after being discharged, and a visit would include a phone call. Sometimes during that phone call, he'll do home assessments the best he can. If the patient has access to an iPad or any kind of FaceTime app, he'll have them walk around the house, kind of show them the different things. He'll take a look at their furnace filters and things like that to make sure they're being changed, that they're clean. Identify other barriers that he might be able to help them with some community resources. And then our bedside RTs. We've really, over the last couple of years, we've tried to get our bedside RTs much more involved. And as far as getting patients to engage with the navigator, they'll make sure that they are encouraging and reinforcing the importance of engaging with the COPD navigator post-discharge. And then transportation. Our navigator works with community resources and insurance companies to identify transportation options for patients. We have a lot of community resources for that. Just to name a couple, we have the Jewish Family and Children's Services, who will provide rides to anyone that is needing a wellness or any kind of healthcare visit. We also have, let me see here, I'm sorry. We also have the Michigan Department of Health and Human Services has partnered with Flint MTA, and they will also provide the same type of services for free. So very good resources for the patients to get to their appointments. And then learning barriers for the treatment plan. So the navigator works hard to try to identify any learning barriers they may have, whether it's reading barriers, anything like that, where they're just unable to kind of grasp how to use their medications. He tries to provide them with resources that will help them with that. So he really makes sure he goes over the home respiratory medications while they're in the hospital, so he can do in-person demonstrations. He'll discuss the differences between the meds. Again, he provides them with pamphlets, with magnets that they can put on the refrigerators. He'll laminate their medication list for them that they can put on the refrigerator. He'll provide a guide for their COPD plan, let them know when they should contact their provider, go to the emergency room or urgent care, as well as contacting their PCP or pulmonologist. So a lot of education happens at the bedside prior to the patient being discharged, so we can hopefully eliminate some of those barriers they may have as far as learning what to do during a COPD exacerbation. And then access to care. Our navigator works closely with a lot of the community health services that can be provided to patients. He identifies and lets them know, depending on where they live, where the closest health clinics are for free health care. He'll provide a list of community resources for smoking cessation, and also, again, transportation is a big key for them, especially when it comes to going to see their doctor or pulmonary rehab. So he works hard discussing transportation resources, what they'd be willing to do, and how they can get there. And then we face a lot of ongoing challenges. Obviously, patients' unwillingness to engage is a huge challenge that we face. We continue to work towards that. We provide patients with some of our positive results that we've had with other patients, and sometimes that will encourage them and give them some hope that engaging in post-discharge with the navigator can be extremely helpful. We also have a very high no-show rate to our pulmonary rehab. Again, that's a big challenge for us. Transportation is a key. Weather is a key here in Michigan, obviously. I know talking to a lot of other directors with pulmonary rehab facilities. You know, the winter time is really tough to get these patients that already had struggled to get around a bit to navigate through the winter months. Again, we try to work with community resources that can give them rides instead of them trying to drive themselves here. And we try to provide assistance to them in the parking lot so they can get into the rehab facility. And again, resources for COPD navigator, that's been a big challenge for us with staffing. Our COPD navigator is also over our lung cancer screening program. So he's kind of being tasked with two roles that have really grown quite a bit, especially the lung screening piece of it. It's grown pretty significantly over the last 5 years. So he's finding his time is a little less than what he would like. So that's where we're really trying to get our bedside RTs more engaged with our patients, kind of having them take on some of the role, especially while they're in-house on education, handing out information, working with some community resources. They've kind of taken on some of the load themselves, which it's been very helpful. So yeah, I'll take any questions at this time. That's kind of an overview of our program and the challenges we face and kind of what we're doing to try to improve our admission rates.
Great. Thank you, Rick, so much for that presentation. It's great to get a better feel for what Hurley has been doing. Did not think I saw any questions come through, but if anybody was working on a question and wants to just ask that out loud, that would also be fine. You can unmute yourself.
Hi, this is Brooke. I just have a quick question. I totally apologize if I did miss this. I stepped out of the car for like 2 seconds, but do you guys connect with like the primary care offices to make sure that those patients are obviously following up, but providing any insight so that those PCPs can make it like a seamless transition?
So our navigator has a pretty good relationship with a lot of the PCP providers. A lot of things that he talks to them about, first of all, he lets them know that he's overseeing their patients. He sends them a letter because a lot of PCPs, you know, you don't want them to feel like their toes are being stepped on or we're kind of stepping out of our lane a little bit and you know, doing things we shouldn't be doing with their patients. So we always provide them with information that we are contacting their patient. A lot of things we look at with the physicians is their medications. You know, if a COPD patient's seeing one provider for several years, we'll find that they'll have 2, 3 steroids ordered, inhalers. So they're really not sure which ones to take. So a lot of times that's where our navigator will reach out to those PCPs, identify which inhalers he would like them on, which medications he would like them on, and eliminate the ones that are causing confusion. So there is a lot of communication and just making sure first that we're involved with their patient's care, and overall that they appreciate it.
Awesome. And then my other kind of question in relation to that. Yes, no, it totally did. And then my other question was, I've done care management for a few years now and more on like the ambulatory side and trying to build that partnership with the inpatient side. And in my time doing this, I have found that some providers do like the COPD rescue packs where they'll kind of basically educate their COPD patients on here's what an exacerbation feels like. You know, these are the signs and symptoms. Should this happen, you know, we have the steroids and the azithromycin essentially already, it's kind of like giving them a script and then to fill it when they need it. Are you finding that to be something that offices are doing? And if so, is that helping with your, you know, decrease in readmissions?
We don't do that. That's a good idea though. We don't have a, so you're kind of talking like kind of standing orders type deal or?
Yeah. And obviously, I mean, you know, we all know that every patient's different, and some patients you're gonna, I guess, for lack of better words, trust more than others when it comes to actually truly feeling it when necessary. So you obviously have to be a little bit picky about who you would have those standing orders for. But yeah, essentially it'd be a standing order to say, okay, here, when you have you know, increase in sputum and, you know, color changes and a fever, whatever it might be, I want you to go ahead and fill this prescription, start taking it, and then call me right after, and then we'll get you in to be seen, kind of a thing.
That's interesting. We do not do that, but I'm definitely going to take note of that. I guess that's what this is all about, right?
There you go. Collaboration is key.
Exactly.
Thank you, Brooke. Sounds like you gave Rick a good idea.
Yeah, thank you for
to
that.
add on.
Yeah, of course.
Awesome.
You know, it's funny. We find that and no disrespect to physicians, but these patients tend to trust the COPD navigator. I think because it's a lot more personal relationship that they develop with the navigator. A lot of times they'll call and ask questions, and Kevin's like, "Well, you should probably ask your physician about this." But
that is very true.
Oh yeah, it's an interesting dynamic.
It is. That's kind of why we're trying to, you know, from the outpatient side, build that care management relationship to help, you know, be kind of that touch base for patients too. So I love it.
Yeah. Yeah.
I do have a question as well. You had mentioned a few different slides about connecting folks with community resources and those kinds of things. One thing that we often hear from members is that they have a struggle with knowing what community resources there are out there that are available for them. Do you have any like advice or recommendations as to how your navigator stays up to date on that kind of information? Because as we know, things are constantly changing.
So we actually have a nurse out in the community who stays very connected with different resources in the community. And our navigator leans on her a lot. Because like you said, being in the hospital all the time, it's hard to really know or recognize when any new services pop up. So she's extremely connected with the community. So he relies on her to provide anything new that comes up.
Excellent. So is that a community health nurse that's employed by Hurley?
Yeah.
Okay. What a great idea.
Yeah. It's been, we've had a lot of success with it. It's been nice.
Yeah. I'm curious if anybody else on the call is doing anything like that. That's something that has is starting to spread out there with other facilities or other hospitals to try to help keep those connections with the community open. Just raise your hand if you don't want to unmute yourself. That's okay. The other thing I wanted to say is really more of a comment than a question, though, is that I really appreciated how the different ways that you looked at your patient population. We don't often see folks looking at all of those different aspects as far as like disability and those kinds of things. So I thank you for sharing that information as well.
Thank you. Yeah, every patient's different, that's for sure.
Kind of going off of that, Rick, I was wondering, you did do, as Jessica pointed out, such a wonderful job of kind of calling out some of those difficulties that your specific community and population might struggle with.
Yeah.
And I was wondering, was there any point at which you connected with the community to work towards identifying what their perception of their barriers to care are, or were these more of kind of the clinical side perceptions
These are what we
of
see.
barriers?
These are what we see from the clinical side.
Yeah.
Yeah, and the reason I show that slide is I think it's important to show everyone the community we're working with. And being a standalone hospital, we are the main resource for a lot of these struggling, high risk areas. So we have to really be aware of what we're dealing with and the challenges they face. So yeah, I think it's really important to show everyone that we have a lot of challenges when it comes to our patient population and the risks that they have.
Mm-hmm. Definitely. Just had a question come in from Julie. She wondered, do you have a community integrated paramedicine program? It's a great question.
Do we have a community? You cut out a little bit.
Paramedicine program?
No, we do not. No.
Julie, do you have one that you would want to?
Can you hear me?
Yeah, thank you.
So we are currently building one right now for the rural community in the state of Michigan. We got a grant. So we have paramedics who are going through the program and getting extra education on wound care, trach care. Items are things that they otherwise wouldn't be doing out in the field other than to manage quickly, during transportation. But the intent of the program is that when the patient is discharged from the hospital, they would make a home visit. And what we are looking at initially the utilization would be high ED utilization patients, and then COPD, CHF, and pneumonia patients, pretty much anyone going home on HOMO 2 for them to follow up. And our home health programs in the area have really embraced it because they're struggling with staffing and not being able to get into the home as quickly as they would like to. And this way, the paramedics would be going and seeing them a couple of times, ideally, immediately post hospitalization to decrease that risk of readmission.
Julie, can I ask you another question about that? And if there's anybody from Ascension Genesis on the call, because I know they have a program as well. But I was curious, I know one of the barriers that folks sometimes have with getting that paramedicine program going is around funding. Are you partnering with another organization or another group that's helping with the funding aspect of that?
We currently are. We are currently collaborating with UPHP, our Managed Medicaid Medicare program in the UP. But again, similar to, your navigator and such, the upfront may not be the cost saving, but the back is definitely the cost saving. So it'll be interesting to see when, the program fully rolls out, the impact. So I don't have any data to share on that at this time, but, again, I think we're all just trying to do our best to decrease the readmissions and improve the quality of our care.
Well, kudos to you. I know that's a hard project to get going. And thank you for sharing that information.
Thank you.
Does anyone have a program where they do in-house visits, like in person? I know we have one little more local in Lapeer, but I was wondering if, because we have an asthma educator that goes and does home visits with pediatric population, and we have really good success with that. But obviously for other resource issues, we're not able to do it with the adult population, but I was wondering if anybody in this group does in-home visits. I know it's a tough one to fund.
Yeah. Again, that funding piece, right? So.
Oh, yeah.
And as I mentioned with Ascension Genesis, I think that they were able to kind of navigate through some of that funding piece by connecting with their physician organization as well and doing some different grant things. So that might be one thought or idea for those that are thinking about trying to start something like that to reach out to.
Yeah.
I did drop the feedback survey in the chat as well. I don't know if you had any additional pieces that you wanted to do before we get the.
I can definitely do that unless there are any other questions. Saw a couple people pop on a video, so I thought we might have more questions coming in. Maybe not.
Can you hear me? This is Heather from McLaren Point Heron Hospital.
Yes, we can hear you,
Hi.
Heather.
I have more or less just a comment. I know that Rick, you had said a lot of these barriers were from a clinical aspect. I am the clinical outcomes coordinator as well as a congestive heart failure navigator for our hospital. So I'm doing the same things that your navigator is. I'm very happy to see that I'm doing those same things. But one of the things that I do is I do a readmission interview questionnaire with patients who readmit, and it's more or less designed to get the patient's perspective on their index stay. And it's, I ask questions on how they were feeling. Did they feel prepared for discharge? How were they feeling the day of discharge? Did they have trouble with the transition of care issues? What caused their symptoms, and what did they do to try to prevent? It gives us a good perspective on how well they felt about their hospital stay. And we've been able to discover some trends that might be beneficial too.
Yeah, I bet. Yeah, that's a good idea. Yep. I've actually heard of a couple other institutions doing the same thing, like so it's an interview when they get readmitted, right? Kind of a what went wrong type questionnaire, right?
Yep. And it
What could we have done?
lets them feel heard,
Yeah.
I think that goes a long way too.
For sure.
Heather, is there any is there a particular resource that you'd be willing to share with the group related to that?
I mean, mine is just one that I sat down. It's actually one that our COPD navigator and I came up with.
Okay.
We just made the questions that we felt were pertinent to helping us maybe discover trends. So it's more or less just, it's not I'd be able to scan it in and send it out if you think you'd like to see it.
I think that might be helpful. I can pop our email into the chat box if you want to send that over to us.
Sure, thank you.
Awesome. Okay, so I'm just going to share my screen briefly again. I can get enough space on here. All right. All right, so last couple of updates. We do have 2 more post-discharge follow-up work groups left in this series. The next will be on September 10th, and then the very last on December 3rd. As a reminder, to achieve the 0.25 P for P engagement points for attendance to the post-discharge follow-up work group series, you must attend all 4 work groups in this series and participate in at least 80% of each session. And then outside of the post-discharge follow-up series, we have an upcoming rural health work group on June 27th and a health and action work group on July 9th. Just as a reminder, all of these work groups occur virtually from noon to 1 o'clock. All right. And with that, we will conclude our work group session today. Thank you so much for attending, and thank you, Rick, for presenting for us today.
Yeah, thanks for inviting me.
Of course. Jessica had included that link to the survey in the chat. It will also be in the follow-up email that I will send out later today. So please be sure to submit that. As a reminder, please select the hospital that you are attending today on behalf of to get attendance credit through that survey. All right. And for anybody who wanted to send in additional resources, our email should be up on the slide for you there.
Thank you very much, everyone.
Thank you.